I think we'll hold questions to the end. Yeah, go ahead. Have a seat here. We'll see if we have time for questions at the end. I would like to introduce our second speaker, who is on live stream. And again, the second fellowship awardee of this session, Dr. Qibiao Wu, who is a research fellow in the Bardisi Laboratory at Massachusetts General Hospital and Harvard Medical School. And Dr. Wu will be presenting on a talk entitled Exploring Signaling Pathways in Combination Therapy. And Dr. Wu.
Yeah, so thank you very much for the introduction. I'm very excited and honored to participate in this amazing event and present our work in exploring signaling pathways and combination therapy in FGFR2 activated cholangiocarcinoma. So, sorry. As everyone knows, FGFR2 alterations are exclusively observed in intrahepatic cholangiocarcinoma, accounting for 15 to 20%, including the missense mutations in frame deletions or rearrangements. So previous studies have demonstrated the oncogenic activity of the FGFR2 fusion proteins, making it a very promising therapeutic target in ICC. And just in recent years, there are multiple FGFR inhibitors evaluated in clinical trials. And in last 2 years, FDA has approved 2 FGFR inhibitors, pemigatinib and infigratinib, for the treatment of patients harboring FGFR2 fusions or rearrangements. So this is a very important landmark because there are no approved targeted therapy in this cancer type before. But although we have seen so encouraging and promising results in clinical trials, we are still facing several challenges in FGFR inhibitor trials. So the first one is that the response rate across different FGFR inhibitors is still relatively low, around 14%. That's compared to EGFR inhibitors or OC inhibitors, could up to 70%. And the second one is that the stable disease is often more observed more frequently than significant tumor regression. And the third one is that the acquired resistance usually occurs within 1 year, and often due to the FGFR2 secondary mutations or to other less defined mechanisms. So we want to ask the question that how to improve the therapeutic response to FGFR inhibition and how to overcome the resistance in FGFR2 activated ICC. So to answer these questions, we first established a set of FGFR2 driving ICC models from patients participating in FGFR inhibitor trials. So this table, the models in this table are all 2D cell line models, except the MG69 is a PDX model. And notably, there are no FGFR2 secondary mutations in these models. So we first tested these models to several FGFR inhibitors, including 2 ATP competitive inhibitor, PEMI and INFI, and as well as 1 covalent inhibitor, filtibatinib. And we include one CCOP cell line, which is FGFR1 dependent, sensitive to the FGFR inhibitor, and 2 additional ICC cell lines, IBE and SNU, which happens no FGFR mutation alterations that's resistant to the FGFR inhibitors. So we can see here the 13-7 and 21 are highly sensitive to the FGFR inhibitors, similar to CCOP1, but not other models. So we further explore the biological effect of the FGFR inhibition using the sensitive model. And we observed that upon the FGFR inhibition, the cells show complete cell growth arrest, but could rapidly resume cell growth when we wash out the drug. And more importantly, we observed no cleave pulp induction upon the FGFR inhibition. So all these results suggest that maybe there's a possible role for the feedback signaling process in limiting cell death or supporting resistance. So we next examine the FGFR signaling output, the MAPK signaling, as well as expand to mTOR signaling and the AKT signaling. As we can see here, despite the durable inhibition of the FGFR2 kinase activity, we can still see the rapid rebound back signaling of the MAPK. So this result suggests that indeed there's feedback reactivation of downstream signaling upon FGFR inhibition limiting the treatment efficacy or driving resistance. So to further identify improved treatment strategies and gain insight into this adaptive signaling process, we perform the high throughput drug combination screening, and we use the 4 FGFR2 fusion models and 2 FGFR2 fusion negative ICC cell lines and 2 additional FGFR2 amplification gastric cell lines to uncover the specific, the potential lineage specificity. So we used a library of 111 drugs and combined with 3 different FGFR inhibitors. So the key of this assay is to look for the cell death specifically in our FGFR2 fusion ICC models. So after the screening, surprisingly, we found that there's a significant cooperative induction of cell death by combined EGFR or FGFR inhibition across the resistant cell lines or sensitive cell lines. So we further validate this result, and we found that the combination treatment could significantly increase the cell death as indicated by the caspase-3-7 activity, and also the induction of the pro-apoptotic proteins as well as decrease of anti-apoptotic proteins. We further show that the combination treatment could actually durably suppress the MAPK signaling as well as the mTOR signaling compared to the single agent treatment of FGFR inhibitor. So considering that there's cooperative induction of cell death between FGFR inhibitors and EGFR inhibitors, we further explore the EGFR signaling status upon FGFR inhibition. And what we found that is the phosphorylation of EGFR significantly increased upon FGFR inhibition, indicating that there's a feedback activation of the EGFR signaling. And the previous studies actually report that the reactivation of the RTK signaling is actually due to the blockade ERK-dependent transcriptional output. And this is the same case in our FGFR2 fusion models as well. And we can see here the negative regulators of MAPK signaling and the AKT signaling significantly decreased upon the FGFR inhibitor treatment. More interestingly, we found that there's one negative regulator of the EGFR, FI1, is significantly decreased upon the FGFR inhibition. So we further assess the role of the FI1 on the FGFR inhibitor treatment, and we can see here there's a progress decrease of the FI1 protein level upon the FGFR inhibition. And moreover, when we knock down the FI1, we can see the dramatic increase of the phosphorylation of the EGFR as well as the total protein of EGFR. So to further link the FI1 with the FGFR inhibitor treatment, we further performed the IC50 AC as well as the immunoblot. As we can see here, the knockdown of the FI1 could actually confer resistance to the FGFR inhibitor. So this data actually particularly interesting because previous studies have demonstrated that the patient harboring the inactivation mutation of FI1 could be very sensitive to the EGFR inhibitor treatment. So we further move to prove the combination efficacy of the FGFR and the EGFR inhibition in our models. As we can see here, the combination treatment could significantly induce the tumor regression compared to the FGFR inhibitor treatment alone, no matter in the sensitive models or the resistant models. And also we can see the full inhibition of the KSX7, it's a cell proliferation marker, and confirm the efficacy study. So all the results suggest that the inhibition of the EGFR actually potentiated response to FGFR inhibitors, both in our CDX models or PDX models. So our study, the take-home message of our study, actually, we have established a set of FGFR2 driving models, and we have observed the signaling feedback upon FGFR inhibition. And we have conducted the high throughput drug screening and found the cooperative induction of cell death between FGFR and EGFR inhibitors. And we further proved that the dual treatment with FGFR and EGFR inhibitors could actually durably suppress the MAPK signaling as well as the mTOR signaling. And we found that this FGFR2 inhibition could cause the feedback activation of EGFR signaling and associated with the transcriptional alteration in intracellular regulators of EGFR and MAPK. And finally, we have proved the therapeutic efficacy of the combination treatment of FGFR and EGFR in vivo using our preclinical models. So finally, I want to thank everyone involved in this work, and especially my mentor, Nabil, and thanks the Cholangiocarcinoma Foundation's support. And yeah, that's all my story. Thank you very much.